Natalia, you have a medical degree, a PhD in genetics from Karolinska, and now you are the medical and scientific director at a longevity clinic in Zurich. That's quite the unusual and really amazing trajectory, because most researchers mostly stay in research. So my question is, what really pulled you towards the clinic in the end?
Yeah, I mean, I would say it's definitely not a very typical trajectory. Most researchers just stay in academia. And I absolutely actually loved academia. And for me, it wasn't really about just like leaving research. I think it was a kind of a internal need, I think, to be kind of on the border between generating knowledge and trying to apply it. Because my medical training is like a very fundamental need in me just kind of I have a duty for care. Always my main priority are, the clients and the patients. And I'm trained to kind of help the person that is in front of me and to do no harm and to think of, terms of responsibility and not really just data. But then during my PhD, like I was working very closely, with basic biology and all the complex trait architecture and things like that. So it was a different way of thinking, like a very mechanistic thinking and asking this first principle questions about what does actually mean to be human, what is biology and what disease really means. And so I think that really changed a little bit my perspective on health in general, how I see health. And I think that's how I navigated that path towards using the ability to kind of generate a lot of knowledge from reading studies and doing research myself, but also then try that to apply it in a very practical form that with the person that is standing, in front of me. So yeah, that's pretty much how it went.
It's so interesting. And if I may add something to the introduction, first of all, welcome, Natalia, on the show.
Thank you.
At second, I'm actually really excited because that's the first time I have a friend here as a guest. And because me and Natalia, we got to meet each other in 2024 in Singapore when we were both part of the Healthy Longevity Talent Incubator at the National University of Singapore. And we've had so many interesting discussions. We've had so many interesting talks about all things related, medicine, longevity, and everything in between. And so I'm really excited for this conversation. I just wanted to say that in the beginning. And I think it's actually really interesting, the background you have with being a medical doctor, being kind of trained to treat in the traditional way, but then having the research background, focusing on genetics and what some people might consider the thing, that's kind of given and you can't really change. And then you kind of, maybe that's also in especially this new field of longevity, a really interesting lens, right? Because we are kind of here at the forefront of trying to treat something that was not even considered a disease a couple of years ago. And so now we want to treat aging itself or the decay over time. And so I think you really have an interesting perspective on that. What would you say, given the background you've had, made you then go into longevity?
Honestly, I think it was just a natural progression, especially when you dive a little bit deeper into genetics. Just clinically, as a medical specialty, I was working in a department of clinical genetics and actually working with a very type of traditional, monogenic diseases. One gene has very specific output and things like that. But then when I transitioned into academia, all my PhD was about the very, complex diseases and doing genome-wide association studies for many different, genomic variances that have very small side effects. So then I think I kind of the lenses of which I actually understood genetic really changed. And then I understood that having, understanding the genetic layer and the genetic background of your own physiology, this is what is a very good foundation in understanding that how to maintain that peak throughout the years. And that's basically aging and how to maintain, healthy in every age. So I think for me, it was kind of a natural progression into longevity.
Amazing. That makes a lot of sense as well. So let's get a little bit more specific, or let's dive a little bit deeper. Like you work at AYUN, which is a longevity clinic in Switzerland, Switzerland's first walk-in longevity clinic. You do a lot of biomarker testing, genetic analysis, all of this stuff. So before we dive even deeper into the science later on, my question is like, what does longevity medicine actually mean in a sort of clinical setting? So what are you doing differently, specifically, than your regular GP, for example?
Yeah, that's a very good question that we usually also get from our clients in the clinic. And what I always try to explain is that what we focus on, that's how basically, I created the medical concept, is that we really focus on understanding physiology before it becomes pathology. And traditional, primary care and GPs are kind of designed to find a diagnosis, and they ask questions like, is something wrong? Is there a condition that I can diagnose? Is this require, treatment or a referral, or, but that system is really essential. I think that's very valuable and it really saves lives. But longevity asks a slightly different question. It's about where are you heading biologically? Are there any shifts in metabolic regulation, let's say, or vascular health, or hormonal signaling, or mitochondrial deficiency, something that is not yet a disease, a symptom, but it is a kind of understanding the pathophysiology, then we can measure basically the progression of where you are in the path of becoming a diseased person. And I think that's why we measure all of these things that we measure. And that's why we really focus on having all of these layers of data, because, the difference is that not that the GPs are kind of missing something, but it's just the structure of their system is really reactive.
I love that. I love that, especially how you phrased the focusing on physiology and treating physiology before it becomes pathology. And I think this is really, maybe some people could not have articulated it that way, but that's kind of exactly what they want to do and what they might already be doing, such as optimizing their sleep, their nutrition, their training, maybe already tracking biomarkers. But now my question is, what does the next level for someone who has already been doing all of these basics, what does the next level actually look like for them? So where does a well-informed, motivated person go beyond the basics?
Yeah, I mean, just to say it very clearly, just the basics really matter. So if you do the basics, it will take you a very long way. But that's just for everyone. But if someone is already doing a lot and it's really consistently sleeping well and it's really aligned with the circadian rhythm, it's, trains already and builds, aerobic capacity and muscle mass and, manages their stress and all of these things, then that really reduces the risk dramatically. But the next level, I think it's not about more hacks or doing more things. It's really about context, that this is where all the different little nuances really make a difference, because then the physiological differences start to really matter. And then when you focus on, like, I can maybe, I don't know, I can maybe give, an example that we've had, in the clinic. We had, let's say,
Sure.
people are coming, and they kind of eat healthy already and they train and, they look physically very good. But then you put them, on the DEXA scan and you do all the blood testing and all these other things that we're doing. Then you understand actually that both of them have very different risks. One of them has, let's say, LP little a, which is a very kind of strong cardiovascular marker. And the other one, carries ApoE4, let's say, that creates then a very different strategy, what it means to be healthy for those two people. So this is why, the
Maybe
next level.
maybe for the listeners who don't know what ApoE4 is, maybe if you could briefly explain what it is and why it matters for people.
Yeah, so ApoE4 is a very, I would say, a common genetic variant it's involved in kind of a lipid metabolism, and it is very highly associated with Alzheimer's disease and with the progression of Alzheimer's disease. So is kind of a already known risk. Also, as is, elevated lipoprotein A or elevated ApoB or things like that we can actually understand. And once you have the data, I think the strategy of how to remain healthy then changes dramatically. And this is where, the next level really matters, because then it's not doing more things, but it's just doing the right things for you, for your biology, for the state that you're in your life, in the context of your life and your current goal. So I think this is where the difference really is.
Yeah, makes a ton of sense. Like when we are talking about this whole optimization or getting to the next level, a lot of people, especially in the like biohacking sphere, think about mitochondria. Like pretty much one of the most abused words in the wellness space, I think. but also one of the most legitimately important concepts in aging biology. So can you give me like the real picture here? What actually happens at the cellular level as we age? And also at what point does that in the end eventually become clinically meaningful, if at all?
Mhm. Yeah, I mean, mitochondria is definitely, we all remember from seventh grade biology, the powerhouse of the cell. That's all, like everyone knows that. But I think that's very true. But also, I would say it's a little bit, incomplete because it's not just, generating ATP or just like energy, but it is metabolic integration hubs. They are sensors of everything. So the mitochondrial are very sensitive organelles, and they sense the whole environment as in kind of nutrients availability. Is there any oxygen tension and redox state, calcium signaling, all the type of inflammatory cues and cytokines activation, all of those things. That's how they decide how to partition energy and how to fuel energy and what type of energy they will actually use. So at a cellular level, an aging mitochondria, it shows, I would say, I would structure it like this. It shows like kind of several different changes. Like first, start to decline the oxidative phosphorylation, which is basically how you create the ATP. And that the whole transport chain becomes very less efficient. Then the biggest, I think, thing that happens, and I think most people actually know about, is when the mitophagy start to be impaired. So what is known that healthy mitochondria are constantly being recycled, and with time, I wouldn't say with aging, but with time, there are different pathways that identify this damaged mitochondria that become very, again, less efficient. So a lot of dysfunctional mitochondria kind of accumulate instead of being cleared. And then those altered mitochondrial dynamics starts to become dysregulated completely. And ultimately, I think that's all in the beginning kind of adaptation, because they are adaptive to the environment. When they sense all of this kind of stressors from the environment, this is how they adapt. But ultimately, after they respond, I would say, to this type of environment and overnutrition and inactivity and poor sleep and all of these things, then there is a turning point when they start to become like self-amplifying their damage. So this is when they kind of drive the disease. I would say this is a different timing. Like in the beginning, it's a lot of dysfunction that they have to deal with. And then at the end, like the whole system kind of falls apart. So at the cellular level, this is what we see. But clinically, I would say this becomes important or meaningful when we start to see a loss of metabolic flexibility. And we see, this is something that we see also a lot of like visceral adiposity, like visceral fat. When we see declining VO2 max, that's a very good sign that something is off. When there is impaired recovery, your HRV is super low. When you have, a lot of inflammation that is unclear why or where it's coming from. So, or worsening, insulin dynamics, which again, we also kind of measure. But at this stage, the mitochondria is not really adapting. This is just, there is a limiting, I would say, systematic limit of the resilience of the mitochondria. So that's how I would frame it. Like early, I would say in life, mitochondria adapts to all the different type of stress and they're very resilient. But after in life, if you really progress of that type of lifestyle and that environment that you create for the mitochondria, that accumulated stress, I think, makes mitochondria actually the stressor. Yeah.
This is so interesting. I really love how you kind of mapped the whole, uh, mitochondrial view out. There's like so many implications this then has. Before we and I have to hold myself a bit back here, because before we directly jump into like the interventions, because I'm really interested in like the mitophagy aspect that you've mentioned and how external stressors such as intermittent hyperoxia training could maybe be beneficial there. I actually want to ask another question before, and that is because obviously mitochondria is a focus of many, and in aging biology and aging research, there's different theories. And then we have these 12 hallmarks of aging, or maybe now 13 with circadian rhythm disruption. And then there's this other camp who says, yes, but there might be these 12 hallmarks of aging, but mitochondrial dysfunction is not one of them, but it's kind of the one that makes all the others worse. And the question I now have is like, is it really driving the rest? Is it correlating with the other things? Is it causal? Where would you rank the mitochondrial dysfunction as a part of aging or as a result of aging and time compared to the other ones who might be genomic instability?
Yeah, I would honestly say it's kind of a little bit of both. That I know that no one really wants to hear that answer, but this is how I understand it. That I think early, as I said, like early mitochondrial changes are mostly kind of reactive to all the different metabolic and inflammatory stressors. And then once mitophagy fails and all this dysfunctional mitochondria accumulate, then they cannot really deal with any type of stress, and they create more problems than solving problems. So I really think it's both. It's just depending on the time when you catch them, even if you are already in a very good state, like your environment is really good and your mitochondria is not really working well, maybe this is where, then you can actually do something because they are not really as reactive to the environment. But if you've already have all this like really bad lifestyle, then it's just I would say that just the consequence of that. Does
Yeah.
that answer the
Yeah,
question?
I mean, makes a lot of sense. And I think this all sounds super interesting to the listeners as well. So I'm just wondering right now, like, for example, at your clinic, I'm sure you're also testing quote unquote mitochondrial function. But what I'm wondering with all the different tests out there, and I've seen a bunch of tests which are maybe not so much evidence backed and maybe do not have like real clinical meaning. So like, how do you personally and at your clinic test mitochondrial function? What do you do with it, and what then follows clinically? Like if you have a bad result, what are you doing then?
So I can maybe just preface this by saying that everything what we do, the way we work at AYUN, like the medical concept is based on layering on different data. So nothing we do is interpreted in isolation. We don't do just a mitochondrial test or just a genetic test. Like we do a lot of different testings just because there is a complex kind of perspective that I think we are supposed to see and understand. And if you can't see one of the things, then you don't really have the whole idea of what really you're looking at. But the mitochondrial test specifically, we tested through kind of an oxygen consumption assay that is performed on the peripheral blood mononuclear cells. So it's not really the mitochondria that is in the muscles or the liver or whatever, but it's a little bit more, I would say, broad and peripheral type of analysis, but gives us a very good cellular respiration profile for, basal respiration, for ATP linked respiration, and for kind of the reserve respiratory capacity of the mitochondria, but also it gives us kind of an understanding of what is the non-mitochondrial oxygen consumption. So we're not really measuring mitochondrial age or anything like that, but we are measuring like how efficiently the circulating kind of immune cells are generating ATP under controlled stress conditions. And I would say this is an important distinction, because then we interpret it in context. When we see kind of a poor result, it means that there is a reduced capacity or there is an increased, non-mitochondrial respiration. And we don't really go directly to supplements. I mean, that's why then we measure and we want to know, like, what is the person's VO2 max, and what is the insulin dynamic, and what is their inflammation, profile, and how do they sleep, and what is their sleep quality, and their training load, and what is their recovery look like. So all of these things then create a very comprehensive picture of what this test really tells us. And also, I would say this is not a diagnostic test. This is a functional signal. And this is, I think, more than we need to know. We don't want to diagnose any disease of the mitochondrial deficiencies or anything like that. We really want to understand functionally whether this is working well under the conditions and the context that we have in front of us. Yeah.
It's very interesting that you kind of also make that differentiation, that you first kind of look at the different sorts of tests you run, and then you kind of
Yeah.
want to see what is telling you what, and how to kind of create a hierarchy, I would assume, of like issues to tackle. And the question I have is, now let's say someone walks in and they undergo all of your extensive testing, and then you find out there's a little bit of everything kind of. their lifestyle is not perfect and they have a little bit of inflammation and their VO2 max is not really great and they have a little bit of, like issues with blood sugar and insulin. You would want to tackle everything at once, right? So you tell them, okay, yeah, I need to adopt a better lifestyle. That's a fact. We all agree on that. But if that person says, yeah, fine, I'll do it. I'll take, I'll make the lifestyle changes and all of that, and I'll stick to an exercise regime. But I want to do more. I want to tackle my mitochondrial quality. I want to improve it. And so if a person says something like that, because I know that you do offer things that might be able to improve mitochondrial function, right? Such as intermittent hypoxia training, which is kind of an interesting mechanism by stressing the mitochondria, kind of getting rid of the bad ones, getting rid of the ones that don't survive this stressor and kind of allowing for more space and more biogenesis of the healthy mitochondria, right? To what extent do you tell that person, yes, let's do it. We'll put you on this protocol. And what do you hope to get out of it?
Yeah, well, the whole intervention part, when you have done all the tests and there is a little bit of everything, it gets kind of overwhelming also for the client because they don't really know where to start and what to do and how to make sense of all of this. So I would say that this is where my strong suit is, because I I see this as a huge, like, a puzzle that I have to solve, like a mystery. And it's a lot of pattern recognition. So from all of these different type of tests, I try to understand what is a repeating pattern that I see for this person. And ultimately that will be kind of his biggest vulnerability for his longevity. And this is where we start. Like we have a prioritization. And this, I work with the team of doctors that we have at AYUN in this type of system. So we have a prioritization where we decide, like, for the first, let's say, 6 months, we really want to target, like, let's say, cardiovascular, like your VO2 max is really bad and there is inflammation, but there is a cardiovascular type of inflammation. And that's where we focus on. And then after 6 months, you come in, you do a retest, and then we understand what went wrong, how fast you recover, how fast you're adapting to all of these new things, and then we go on. So it's kind of stepwise approach with a lot of education and a lot of conversation with the client as well. And when it comes to all of those people who, let's say, okay, I'm going to do everything, but I want a little bit more, and they want to do a little, some of the treatments that we offer, that's also based that on a very personal basis. Like, we decide for the context, for the person, do they need it? How much of that they need to do? And what is the goal? And what do they want to achieve? And then what would be the outcomes that we want to measure? For some people, they might do an IHHT protocol, but we want to measure sleep outcomes. And for other people, we want to measure insulin regulation outcomes. So it's for every person, it's a kind of a different plan, a different program, and it's very, very personalized. However, the IHHT that we have, it does help as a very useful kind of stressor for the mitochondria and basically adapt or train your mitochondria to be able to deal with that type of stress. And that really, a lot of studies, there are a lot of human functional studies that have been done to show not only like better just performance, but your VO2 max gets a little bit better, your insulin resistance gets better, like the metabolic flexibility improves. There is, in a specific type of population, there were studies done for people with a lot of benefit for regulation and things like that. So overall, I don't have to say, like, all of this is super personalized, but it is decided based on, like, the context that we see it in.
Interesting. Just to
Interesting.
jump in for the listeners to understand, IHHT stands for intermittent hypoxia training, which is kind of an oxygen device where you simulate altitude training, right? By being a couple of minutes in an environment, meaning through the mask and the oxygen tank, to where you simulate the conditions of altitude training through breathing air that is lower in oxygen than the regular air, right? And then you kind of have these trainings where you go take these dives, as some people might say, where you are in these like low oxygen environments, and then you do it for some protocol a couple of times, usually in a given time window of like 40 minutes or whatever it may be, just for the listeners to be able to follow what we've just said. But yeah, Nico, I didn't want to cut you off.
No worries. What I'm wondering now is, or for example, I talked to some pulmonologist MD back in the time as well about this IHHT topic. So what I'm wondering is, are there any downsides? For example, what he told me, the pulmonologist, is that in certain cases, if you have some specific preconditions, it may actually harm mitochondria. Like, how would you respond to that topic, and what's your general view on that?
Yeah, I mean, of course, we screen people. There are some contraindications for IHHT, and that usually is for people who already have like limited lung capacity, or they have some kind of chronic diseases that will not be actually very beneficial to do this, or to stress their system even more and create even more, I would say, inflammation. But this is obviously something that we test, prior to whatever decision that we make. That's why also we do all of the different testings to be able to assess whether this would be, first of all, safe for the person that we want to do it to, but also whether it fits their program and goal in general.
Interesting. Okay. I want to bring in a dimension that's very close to my heart. It's the environmental dimension, because I think it's underrepresented in the whole conversation around longevity and health optimization and also mitochondria. Because I do read some theories or studies that kind of link mitochondria as being very sensitive to environmental loads, like toxins and chronic low-grade inflammation, air quality, and all of the other things we are exposed to that might not be the best for us. My question is, how much of the mitochondrial dysfunction that happens over age is really driven by time only, or maybe also an accumulation of exposures that are harmful to mitochondria and human health in general? What would you say? How much weight would you put on that environmental dimension?
Yeah, I mean, as I said, like mitochondria are very extremely sensitive to the environmental inputs. And they are, this metabolic sensors. And so when there is a chronic exposure to pollutants, or there is a persistent kind of low grade type of, either infection or metabolic endotoxemia with a lot of toxins with you around you, heavy metals and things like that, that can definitely impair mitochondrial function. That's for sure. But so I would be also careful, because for most people, they don't age prematurely because of the toxin exposure, I would say. They age prematurely because there is a chronic metabolic overload and low aerobic capacity and inability for the mitochondria to exercise their kind of resilience and be the most efficient that they can be. And I think that the environment has a lot of input, especially the toxins. But there is, I would say, a hierarchy. I would say the first layer that it will be probably the most important for like the active functional mitochondria would be a metabolic environment. The energy surplus and its inactivity, sleep. I cannot stress enough like how much important sleep is and sleep disruptions. And then the second layer, I think, would be the inflammatory environment. But that's also inflammatory environment within your body, like excess adiposity and gut integrity, lining of the gut, and immune activation and things like that. And then I would say the third layer that will really kind of already make things really hard and really heavy for the mitochondria would be all the kind of exogenic, I would say, toxins that we see and heavy metals. We don't really assess that, I would say, very regularly. I would say we do that contextual. Like if we don't assume that the mitochondrial dysfunction is because of the different type of toxin, but we want to see if there is we already know that there has been exposure. Some people have, different type of work environment where they're exposed to toxic metals and things like that. This is where we kind of think about it a little bit more deeply. But I think that just, time doesn't really damage mitochondria on its own. I would say there is a cumulative stress that happens, and that environments really define what the stress is. And sometimes it's toxic, but sometimes it's just, not sleeping well. Yeah.
Yeah, couldn't agree more. I think also like not enough people, or like most people always want to have this magic cure, or want to do, I don't know, like first focus on the things which don't bring the most benefit, but skip the basics. And that's why I love the idea of this hierarchy you just mentioned, and I'm a big fan of it myself. But I want to switch topics for now. I want to talk about genetics, which I think is also an extremely interesting field. And I mean, you've been inside genetic research long enough to also pretty pretty much have watched the field revise itself significantly. I mean, from like candidate genes to genome-wide association studies to polygenic risk scores, for example. Like, what did you believe 10 years ago that you now think was either wrong or at least far more complicated than you understood back then?
No, I love this question because I have been thinking about this for a while and also been talking to a lot of my colleagues because the field of genetic has had tremendous change, and I think more change than we could ever, comprehend when we all started working in the field. So I would say for me personally, it would be like 10 years ago, and I think everyone else in the field, maybe, some very bright examples. I think I really overestimated that kind of the explanatory power that genetic would have, like the individual genetic variants. And then, coming from, as you said, like early kind of candidate genetic work, I think there was a kind of hope that we would identify, the gene for a specific trait that will kind of explain everything. And it was a very decisive variant, that would kind of meaningfully change biology, and it will all make sense. But then when I started working on genome-wide association studies, I think I thought, and it really it humbled me, I would say, that the most common and complex diseases are massively polygenic. So every variant contributes a like very tiny effect size, and the risk is really distributed to thousands of loci, like genetic loci. And I believed that the idea that genetic would give us like a very clean deterministic answer. I think that was my bias, because it didn't. It really gave us kind of a probabilistic, I would say, gradient. And even now with the polygenic risk scores, they are very statistically powerful, I would say, on a populational level. And they often explain, modest proportion of variance, but I think their use will be very, very valuable in determining and stratifying risk, like years before you even, have any type of symptoms, which I think it would be very, very amazing. But then I would say the second thing that I underestimated was the gene environment interaction. And I think the variants, like genetic variants, very rarely act just in isolation. Like there are cases, that's why they call, rare diseases, where there's only a gene that happens and you have, a protein that doesn't work and there is a specific mutation and you're born with, different type of deformities and things like that. But those things are much more rare. The expression and the downstream kind of impact of the genetic really depends on the environment and basically where you put it. You have a basic genetic vulnerability or potential, and how that's going to develop really depends on the environment that you put it in. That was my kind of big breakthrough for genetics. And then clinically, I think that would make me a little bit more cautious, to kind of understand that genetic doesn't give a certainty like people thought, but it was probably a lot of probability under specific context. And it's very difficult to explain this to a lot of people because it's all about interpretation. And once you get, comfortable understanding what genetic really tells you, then all of this thing makes sense. But it is a path.
I think I'm sorry to say something here, but Natalia, I want to give you so much credit for being this humble, because I know you, and I know how incredibly competent you are, and yet you approach this whole field with such a level of humility that I just think is remarkable. And I think it's exactly people like you should be driving the field, and I'm happy that they are in your case. And so I just wanted to give you credit for that, because it's every time we talk about things, I always notice how open and curious you are also about things we don't know yet. And so I think that's an outstanding trait. And I'm really glad that, you share with everyone what we know already, and also where, things might be heading towards the future, because, we always need to be open, curious, and critical. And I think you really embody that. So yeah, but I want to give the word to Nico, because I think he has also an interesting story with lifestyle genetic reports. Maybe you want to take over from here, Nico.
Definitely, and couldn't agree more. That being said, as Miguel already mentioned, during my time in Berkeley, when I studied abroad in the US, I did do some genetic analysis myself, which was with self-decode back then, cost like $500. And then after, I don't know, like 4 to 6 weeks or something like this, I got my results. And then when I first opened my results, I was shocked. There were like 1,000 different things in there. And I was like, what the heck is even going on here? Like, I couldn't even scroll through this. And I was like, everything is red, then orange, yellow, green. And I was like, holy shit, what's happening? And that made me realize there are so many different things in those quote unquote lifestyle genetics reports, which in my view, or like for myself personally, had like more anxiety rather than any huge benefits. And then also, which is really important to me as well, for example, in this report, they told me that I have a really high genetic risk for atherosclerosis, which in the end made sense because I have a really high Lp(a), which is obviously one of the biggest cardiovascular risk factors. And they have some good data backing this up. But then also, for example, they told me I have a really high chance of developing knee pain. And I was like, okay, that's interesting. And then I looked into it, and this was pretty much based on some mechanistic data, which isn't even close to being on the same level, but they just put it side to side. Like a quote unquote normal person couldn't really tell the difference between them. So what I'm wondering, like in those lifestyle genetics, MTHFR, cont variants, various detoxification polymorphisms, all of this, there's so much stuff out there. And then also those quote unquote medical genes who have established causality like ApoE4 or BRCA1 or 2. Like, how does a normal person differentiate between all of those noise?
That's a very good question. And I honestly don't think that a regular person can differentiate. I think honestly that a lot of like people from the medical community can't even differentiate. And I'm saying this like with all respect, and I know how difficult it is and how complex it is. And I kind of invite people to share their knowledge and to share their data because it is very, very complex for everyone. But how I think about it, because obviously I have been working with this for quite a while. I mean, I think, the problem isn't that if the variant exists or not, because they do, but the problem is always how they are interpreted. And I think there are, as you said, like there are so-called high penetrance variants, like the BRCA genes and, for in the right context, or the gene for familial hypercholesterolemia. That's actually, that has clear guidelines and actually changes clinical decision. Like there are things that this is not lifestyle trivia thing that where you can try this or that. Like there are guidelines what to do specifically if you have those genes, because they are kind of more deterministic. But for all the variants, as you said, like the MTHFR and the COMT and all of these different type of polymorphisms, they are biologically real. I mean, there is extensive data, I would say, for some of them, again, depending on the population that has been kind of analyzed and all of that. There are solid studies, I would say, showing association between specific type of mutation variants, I would say, like polymorphisms, like the MTHFR, and reduce enzymatic activity or efficiency that really alters the folate metabolism. And this is actually real. I mean, there is a 60% of the population that carries maybe one of these variants, and we see that they cannot really metabolize, I would say, the folate specifically well. And we can see also that, and also in the clinic, we see that a lot in the context where we have a lot of elevated homocysteine levels, which is kind of a part of the whole methylation cycle. And it is kind of the most functional way to measure methylation. So when, again, I have to say, we don't use that data, and you shouldn't use that data in isolation. It always has to be put in context. And if you do have a genetic test and a genetic variant, you always want to follow that up with any type of like other measurement, either it's a performance measurement or a blood test or any type of monitoring, because otherwise you cannot really understand what the genetic really means in itself, So in our practice, I would say, and this is also a system that we use with our doctors, that when we do have a genetic kind of high priority for people who have this type of polymorphisms, we don't interpret it, or we don't assume that there is some kind of dysfunction, because we always then check homocysteine, and then we check the B12 status, and we check the folate levels, and we assess inflammatory markers. We want to evaluate, dietary intake and your gut lining and the microbiome. So all of these things kind of put the whole picture together, and we can understand, like, even if you have that basic genetic potential risk, how fast or how much of that has already been manifested. So this is where the interpretation comes into light, because you can get all the data in the world. Like now you can sequence obviously the whole genome for very, couple $100. But then how you interpret that, it's very, very crucial. And it is complex, especially for, complex diseases and the polymorphisms that are not very deterministic. So again, you always have to look at it in very different layers with very different data together. Otherwise, it's really difficult to say what the benefit is.
I think it's great that you kind of essentially say that we need to see the nuance with these things. The question I still have though is that if we kind of say, there's this thing that is kind of fixed, which is our genes, whether you have in the MTHFR variant or which one you have and how much of that enzymatic reactional capability is reduced. Is it 40%? Is it 70%? Or whatever it may be. And then there's the other thing, which is like your current state. So you kind of have that, like your foundation that you can't change, and then you have the kind of the floors that you build on top that you can change, that you can like remodel, and especially with things like MTHFR and maybe COMT as well, but I think MTHFR is really the most prevalent one in all of the biohackers discussions. How exactly, what exactly do we do with it? Do we say, okay, we have, you did a genetic test and you see you have the MTHFR polymorphism, but your homocysteine is fine. Like your levels are 6, whatever. So they're not elevated at all. Do you then say, okay, you do have the genetic, potential to develop an issue there, but it's currently not there, and we can safely exclude it by just looking at homocysteine? Or are there other things we also need to include? And same also for COMT. Is it because it does affect the breakdown of neurotransmitters, right? Is it then that we say, okay, we kind of look for a way to test for the whole neurotransmitters, and then we make our decision based from there? But then you could also argue that we don't need the genetic test in the first place if we only focus on the current state, right? So where would you put the weights, and why do we kind of need both if we want to make the best decisions now and long term?
Yeah. For me, I think it brings a lot of value when you get that layered analysis, like when you get the genetic risk, because if you do have a genetic risk, it means that you will always have that risk. And what we want to see that how that is phenotypically expressed. Because we also have a lot of people in the clinic. I mean, they're coming with very high, risk for, coronary artery disease, or they have this MTHFR genetic variant, but when you test all the other things, like homocysteine is optimal, and then ApoB is fine, and then blood pressure is fine, and their VO2 max is great for their age, and then they have no basically inflammatory markers, everything is kind of low. Your genetic risk obviously is still there, but there is no phenotypic expression. In that situation, we don't really escalate. We just understand that this is, if something goes wrong though, and you for some reason stop exercising as much, or you have a lot of stress in your life that you cannot manage, or you start eating a lot of junk food or whatever, then you have to understand that in a person who doesn't have this type of genetic mutation, it will take them a lot of eating junk food, like months, until they actually get some kind of issues. But for you, that will be much faster, much, so it really drives a lot of the strategy, like how aggressive we should be with the strategy. So again, it is a nuance, but already when you're doing a lot of things, you really want to understand like what and how you're supposed to do and what it works specifically for you. So the genetic really, for me, it gives us a lot of understanding of how aggressive or what the strategy should be like, even if you do have the risk. And then you get the layer of the phenotypic expression of whether you are already in a state that is really decompensated, so you have to be super aggressive, or you're already fine and your body kind of figured out a way to cope with that risk, and you are actually healthy. So it's you have to monitor everything.
Yeah, that makes a lot of sense. So what's really important is, I mean, personalization is really important. Nuance is extremely important, but then also expert guidance, as you already mentioned, to just skim through all of the data out there and really have someone guiding you the way, which is, in my view, as well, extremely important. I want to quickly talk about the structural issue in general. I really keep coming back to when I think about it, sometimes, which is what gets studied is like substantially shaped by what has commercial upside, which makes sense economically as well. So like, for example, patentable molecules which attract funding, obviously, large trials then get built around them, which makes sense again. But a huge amount of what matters for longevity really sits in the zone where the mechanism is somewhat well characterized biologically, but a large trial will, if we are being honest, probably never be funded because there's no patent at the end of it and no real monetization opportunity for the companies who fund the research, which are pharma companies most of the time, or governments, government grants. How do you navigate that as someone trying to practice rigorous medicine?
Yeah, I mean, that definitely creates kind of asymmetry, But I think the answer to that is not really to lower the bar for evidence, but it's really to interpret different type of evidence appropriately. So I would say in practice, if something does have kind of a large randomized clinical trial data with very hard endpoints, that really carries the highest weight, obviously, for all of us. But if something has, strong mechanistic plausibility, human data, and, there is a low kind of downside risk, and it aligns with like evolutionary physiology, I would still, it may still justify, cautious implementation, but especially in prevention, like that's, I can, like, for example, this is a good example. I don't think there is a 30-year randomized trial that proves that zone 2 training expands lifespan, But we have a lot of strong data linking cardiorespiratory fitness with mortality, and that there is a strong physiological understanding of how aerobic training really increases mitochondrial density and improves endothelial function and, enhances insulin sensitivity. So that I would say that's enough to act. And also the downside of doing a lot of zone 2 training is very, very low. Like there is not really a lot of downside. So I think it's safe and it's plausible. And I think when used cautiously, and then you can always anticipate if there is any type of risk. You can always anticipate what is the thing that's going to happen or what are the things that you should measure to be able to really do it in a responsible way. But I would say like mechanistic, plausibility, it's not really a proof, but also the absence of a patent, it doesn't mean that there is an absence of truth, you know what I mean? Because evidence has different levels. So integrity means that kind of knowing which level you are really standing on and what is the kind of what you can gain out of that in a safe and responsible way. And this is how I think about it, because especially now, there is a lot of science, created, and the fact that there is a peer-reviewed study online, that does not mean that that's kind of the whole truth. And the other thing is also true, that there is no study for zone 2, but then we know that it's good for you.
I think it's so interesting what you're mentioning, because essentially what you're saying is that with all of the studies that we do, and that unfortunately we don't even have for many of the things, but even for the ones we do, we try to get to the truth, right? But it will likely always only be a proxy of truth, and we'll try to get as close to it as possible, but maybe we'll never reach it fully, right? And then there's always this degree of uncertainty. And I can definitely relate to that because, I've been dealing with complex chronic illness, and then I have made some decisions that, are very outside of the, what conventional medicine would say you should do. I've done inosphoresis and all of these things. And I'm a big believer in kind of informed consent and like individualized risk reward assessment, because the situation might be very different from person to person. And I always think it's about bets and kind of thinking about what's the cost of not acting and what's the cost of acting and what's kind of the risk reward assessment of both. And I do think it's interesting because, whether it's you from being sick trying to get healthy, or whether it's someone being healthy who wants to live a long healthy life and wants to extend kind of his longevity. I do think that there's quite a bit of overlap, because what's the cost of acting, what's the cost of not acting, and how do you work with your patients to make them understand kind of the risks of doing something or not doing something?
It's just a lot of conversations, honestly. Like we spend so much time with the clients. So every client that comes into the clinic, like they spend at least like 3 hours with the doctor in different, touch points. But it is a lot of conversations and it's a lot of education and it is a lot of explanation what this really means. And it is, I think for them, at one moment it becomes really important to understand that also there is a cost in not doing anything. Although it feels safe, but there is also a choice of not doing cardiorespiratory fitness, of not doing zone 2. I mean, that's also the risk there. I would even argue that probably that's a bigger risk than actually doing something. So there is a shift in mindset that happens with a lot of people that actually come through the clinic. But that, as I said, that takes a lot of explanation and a lot of conversations until they actually get to a point where they actually understand why this is all important and what it is, how we decide the benefit and the cost of doing something without doing or not doing something. Because if you really focus only on the evidence, that's very limited in a sense that we only have a lot of evidence for drugs, for supplements, for something that you can take, but not a lot for some stuff that you can do. And I think this creates a little bit of shift in mindset. And most of the things that you can do are just inherently safe, I would say. I mean, it's optimizing your sleep again, and, exercising and zone 2 and, making different choices of how you kind of distribute different nutrients and things like that. I think that makes a lot of difference already, but it is a mindset shift, I have to say. It is a lot of, explanation and a lot of communication with our clients.
Yeah, that makes a lot of sense. What I'm wondering right now is how do you handle a person, for example, who's coming into your clinic and has a list of, I don't know, 150 different supplements. They want to do 60 sessions of HBOT, IHHT, red light panels, gold planters. They really want to do everything. They really want to optimize their whole life, every bit out of it, the last 0.1%. How do you handle that specifically?
We do have those, I have to say. We have those. And I think, again, we approach as the same as we approach everyone. You really first have to go through all of the testing because that gives us kind of the layered understanding of your own physiology. And then we can actually decide whether all of the things that you're doing are actually beneficial. What is the goal, why you want to do this, and how to go about it, and have kind of a stepwise approach where we decide what is the priority for you right now. And so sometimes it's also difficult for those people to tell them stop taking all of your supplements. At some point you have to kind of trust or leave the body to be able to handle all these different kind of pressures without the supplements as well. I think sometimes you just need a reset, But it is, some of them are, I would say the good thing about those type of clients is that they are very willing to do a lot of things. So it's very they're very collaborative. So they go through the whole process and all the testing, and they really want to do everything. But if you give them a clear, systematic line of approach of what you're supposed to do and how and when, they will do it. And I think that's an amazing kind of skill that they have, because then we have a lot of the different type of clients that they do come and, want to do things, but then they don't really do it at the end,
I can certainly imagine. Okay, Natalia, as we're coming to the end of this episode, we want to go over to the rapid fire questions, also what we call the hot seat, where you'll be asked a few questions and your answer needs to have a length of 30 seconds or less. So I'd say we'll just jump in directly with the first one being, what's the most overhyped longevity intervention right now?
The most overhyped intervention. This might be a little bit controversial, but I would say everyone that is taking NAD plus and infusions and things like that. I just have not seen a very good data out of that. I don't really know what is going on and what is happening and why there is such a hype and why people want to do it so much. And there is, I hear all of this people coming and saying that they felt amazing, right after they do it. And I believe that. I'm sure they do feel amazing, but really, again, putting both together, having the scientific understanding of whether this makes sense, whether this is safe, what is kind of the mechanistic process of what is actually happening within your cells and what all of those things. I really haven't found very good confidence studies to say this is something that you should definitely do. That would be my take.
Yeah, makes sense. What's the one biomarker you would track if you could only track one?
Well, if I could only track one, it would probably be VO2 max.
Interesting. Okay. Then what's the supplement everyone or many take that you think is mostly a waste of money?
I mean, we did talk about the electrolytes before we started. So maybe I would say, electrolytes are very useful and they're great. And I would say if when there are specific times where you really do need them and can really give a lot of benefits, but those like the body itself, the physiology is created so that the body is able to maintain a very good balance between all of those little micronutrients. And I think that is something that people spend a lot of time thinking about where they don't have to. I mean, that's something that your body really does already very well. So spending a lot of money on, electrolytes, if you are a marathon runner and training for Ironman or something, yeah, take it. That would be good for you. But if you are like a regular person who goes to the gym like twice a week,
What if you're on a low carb diet?
I mean, I would still like if you hydrate enough and if you have the different kind of variety in your nutrition, I think that's enough.
Interesting. This one is a bit more personal. What's one thing you do for your own health that you can't really justify with evidence?
Yeah, this is interesting. And I think this is maybe more of a woman's thing, but I have become very, very well attuned to my needs and my body and what kind of stresses me out and what really improves my recovery throughout my cycle. And I'm very aware of the different phases of my cycle now somehow. And I haven't seen also a lot of data to justify that this is how it's supposed to be, but I see it in myself, like the need for different type of nutrients, the way I train, the way I recover, my sleep getting better or worse. So all of these little kind of things, it shows what are the things that are not in alignment, with me right now. And I have become very aware of that. So that's something that I don't think that I can justify with a ton of data. And I hope there will be a lot of data to support that. But so far that's probably it.
But it's interesting because, just because there isn't a ton of data yet doesn't mean that it's not true. And maybe there is this innate body's intelligence that kind of requires different inputs at, different phases of the cycle. So I do think it's very interesting. Now another question. What's kind of the longevity metric that you think will matter most in 10 years that nobody is talking about right now?
Sleep. I mean, I really cannot stress enough like how important sleep is and how underrated sleep has been and how people taking it for granted. But it is really the kind of the oldest evolutionary, process that we have accumulated throughout like millions of years of evolution. And I really think that it's crucial to our existence. And this is not, said lightly. And I really feel and I hope that the science will catch up and there will be a lot of easier ways to really track your sleep, not like a proxy of your sleep, but just really understand the quality and really understand even more of how to optimize it. Because now we are kind of, starting to understand a little bit, but I feel like it's still like the dark ages. So I hope in 10 years, there will be some miraculous way of us to understand how to sleep amazingly and the best quality, because I think that will change a lot.
I hope so too. Another personal question. What's the best health decision you've made in the last, let's say, 12 months?
Again, this is, again, I would say optimizing my sleep. That has been kind of the most important thing that I've done. I really have focused a lot in this, specifically the last year, in really, really optimizing and tracking my sleep and knowing when to take what type of supplements. Because I've become, so attuned also to my body and depending on my cycle and all these things. So I think optimizing my sleep has been the number one thing that I have worked on this year mostly.
Interesting. Okay, because you've touched study and more data and all of these things. If you could run one study with unlimited funding, what's the first thing you would want to test?
I would really want to, again, make a study for women's health and focusing on women's health. I would like to make like a longitudinal 30-year analysis or 20-year analysis with starting, I would say, with women in perimenopause and like follow them throughout until they actually get to menopause, but stratify them with different kind of arms for metabolic, kind of biomarkers, and then cardiovascular health and hormonal different type of biomarkers. And the outcomes, I think it would be something that you can actually practically measure and have all the brain MRI scans for, estrogen metabolism and analyze, bone density and fracture risk and all these things. So this is something that I would love to do.
Yeah, and I
Amazing.
definitely need to do a second episode on women's health.
Yeah.
We do. Looking forward to this already. Okay, the last question, the we turn on health question, which pretty much every guest has to answer. If you could change one thing in the current healthcare system, what would it be?
I would definitely want to see insurance incentives for prevention. I would like to see, reimbursement for prevention testing and longitudinal metabolic tracking and, fitness assessment. That will change the game in general. And I think that only if we actually be able to do that, that will add, years to our lifespan, to be honest. I really believe that. Because, by the time people obviously reach the hospital, like the biology has started drifting like 30 years ago. And I think that's why we haven't really been incentivized to act earlier. And if that changes on a kind of a structural, systematic level, that will make a lot of difference.
Yeah, love that. So
Couldn't agree
that's
more.
my- thank you so much. This was exactly the kind of conversation we started this podcast for. And again, I'm personally super happy about this kind of, for the first time now, bringing a friend on here and discussing things that are actually so valuable for the listeners. And so thank you from the bottom of my heart for coming on. And yeah, looking forward to a second episode about women's health in the future.
Yeah, thank you very much for having me, guys. And it was really, really exciting to talk about all these topics that I usually think about a lot on myself by myself. But now it's really, really nice to be able to actually go into the depths of things. And it's an amazing podcast that you have started. And I wish you all the luck.
Thanks a lot.
Thanks.
All of your socials are linked below. And yeah, see you next week.